You're listening to episode 137 of Present Moment. Welcome to Present Moment, Mindfulness Practice and Science. I'm Ted Meissner. Present Moment is a podcast with interviews, conversations, and roundtable discussions. We speak with mindfulness teachers about their newest findings published in peer-reviewed science journals, teachers about their understanding and methods as they work with students of mindfulness, authors about their books and interests, and we also speak with everyday practitioners. The website presentmomentmindfulness.com has show notes for each episode along with resource materials. Dr. Zev Schuman-Olivier joins us to speak about mindfulness training for primary care. If you're listening to this podcast and find value and insights from what is shared here, know that this is made available from your generosity and the generosity of others like you. I want to thank those of you who are making monthly donations to keep this podcast going. And if you're not yet, please take a moment, go to presentmomentmindfulness.com and click on Make a Donation. One-time or especially monthly donations show you value this work, which can't happen without you. Thank you for your help, your support, and your kind generosity. Mindfulness can be helpful in the reduction of anxiety and depression, as well as other chronic problems where self-management plays an important role. New models that include referrals from primary care providers can greatly enhance a person's accessibility to beneficial mindfulness programs. Dr. Zev Schuman-Olivier is the Medical Director, Addictions, Cambridge Health Alliance, an instructor in psychiatry, Harvard Medical School, and a board-certified addiction psychiatrist with expertise in opioid use disorder treatment and substance abuse treatment for people with co-occurring disorders. After graduating from Tufts University School of Medicine, he completed psychiatry residency at Harvard Medical School Cambridge Health Alliance and the HMS Addiction Psychiatry Fellowship. He trained at the Massachusetts General Hospital Addiction Recovery Management Service, specializing in addiction treatment with young adults, and is a member of the Massachusetts Medical Society Opioids Task Force. Our guest today is Zev Schuman-Olivier. Zev, welcome to the podcast. Very glad to have you here.
Thank you for having me.
So before we get into the really quite extensive work that you've been doing at the center where you are, I'm wondering if you could tell us a bit about your background.
Well, I am a board-certified addiction psychiatrist who has primarily, when I'm not working with mindfulness, has been working to treat people with substance use disorders and opiate use disorders for about 15 years. Before that, I was actually an electrical engineer, biomedical engineer, really interested in how to make technologies that could help people who were suffering. I was particularly interested in neuroengineering, to be honest. And at some point, I realized actually that mindfulness and meditation might be faster, safer, and much more effective to help people who are suffering and who are challenged either with substance use or mental health, and all of us actually. So made that big turn from engineering to mental health, and ultimately to this mindfulness and addictions and mindfulness and behavior change work.
And I imagine with the opioid epidemic that this country is suffering from, and in particular, as in the East Coast, I seem to think that's a bit stronger than I've seen it elsewhere. I imagine you're quite busy and have a lot going on with that.
It's been a busy decade. We're lucky to say that in our region in Massachusetts, the overdose rates have at least stopped rising with the treatment structures that have been put in place in our region. But there's a lot of work to be done.
Yeah, yeah. I'm wondering if you might also say a bit about the Center for Mindfulness and Compassion, where you are. Many of the listeners may not be familiar with that.
Sure. Well, the Center for Mindfulness Compassion actually was officially founded in 2014. It was somewhat serendipitous in that one of our first year psychiatry residents at the time happened to be meeting at a Meet the New CEO meeting, and the resident proposed a mindfulness center, and the CEO was open-minded and interested. He's a really mission-driven CEO and felt like this could align very well with our mission at Cambridge Health Alliance, which has always been about compassion and creating a community of caring, and felt like this could align. So myself and several other faculty members who have been involved in doing this meditation and psychotherapy work for probably about a decade before the center started, came together and put together a proposal for our CEO about a Center for Mindfulness and Compassion, and with an idea that the center would really integrate 5 different functions. So the first function would be a clinical function, being able to bring mindfulness to our patients throughout our healthcare system. The second was to do education and training. As a hospital affiliated with Harvard Medical School, we felt like we were in a good position to be able to train new medical clinicians and other clinicians as a training facility. We also really saw an opportunity for staff and employee well-being across our healthcare system, which is the primary safety net healthcare provider for the Metro North Boston area. We also really saw opportunities to do integrative research, not just bench research, but especially translational research and clinical implementation research and dissemination research, and research focused on health equity, because that's been an area of research focus for Cambridge Health Alliance for a long time as well. And then the fourth area was also really integrating mindfulness and making it available for our diverse communities throughout our region. And so really with those 5 different areas in mind, we saw that there could be synergies for a center. And we really saw as the initial core project that we proposed was integrating mindfulness across the healthcare system at the level of primary care. So our healthcare system covers 5 different cities in the Metro North Boston area. They're all urban cities with a very diverse population. And what we really saw at this time was, as the ACA had just been passed, the Affordable Care Act had just been passed, that patient-centered medical homes were something that was really being encouraged. And we really felt that as our hospital went through this transition to create patient-centered medical homes where specialty care was brought to primary care, and patients were supposed to be able to get all their needs met at their primary care site. That really at the core of patient-centered care, at the core of accountable care, which was one of the other mechanisms that the Affordable Care Act really created, was the accountable care organizations. At the core of both of those really is people's capacity to self-manage their own chronic illness and their own health maintenance. And when you look at the American healthcare system, primary care really is the heart of the healthcare system. It's where it directs you, to the rest of the parts of the body. It right. Infuses the oxygen, into the rest of the healthcare system. It is where the warmth is supposed to come from, and it's supposed to carry that warmth throughout the rest of the healthcare system, though it doesn't always do that as much as we hope it would. And unfortunately, when it breaks or it's not working for people, their health can fall apart very quickly. And so the idea was that if we could really target and develop mindfulness program that specifically could be integrated into primary care and these patient-centered medical home model, and that could be insurance reimbursable and referral based, that we might really be able to provide an important piece of the puzzle in helping mindfulness to be more accessible and more inclusive and more diverse. Because especially in 2014 when we started, mindfulness groups were largely filled by white,
Right.
middle to upper middle class, educated folks. And we really felt like for mindfulness to be able to be accessible in the healthcare system, it has to be accessible and adaptable in ways to support our diverse communities. So it was kind of with that goal in mind that we set out trying to think about how to solve this problem of actually integrating mindfulness into the healthcare system instead of it being something that's separate and it's only for those who could pay out of pocket. And so there was actually about a year-long process of really working with stakeholders throughout the hospital system at every level, from departmental leadership for multiple departments involved in primary care and mental health, to executive leadership, to IT specialties, to get electronic health record referral processes set up across the system, to working with front desk staff who weren't used to dealing with mindfulness groups in evenings in primary care settings, to space and facilities people to be able, experts to be able to help us to make sure that we had the right space in each of the regions where we were working with the program. And the kind of list goes on. As part of that, Cambridge Health Alliance Primary Care was going through this transition, and it was very stressful for the clinicians, and the executive team and primary care management really wanted to support all the healthcare centers. We have 12 adult primary care centers across the 5 cities regions. They really wanted to support everybody. So part of that was supporting our center to go and offer at least one mindfulness 60-minute intro session to all staff and all the primary care. And then we also offered primary care providers, nurse practitioners, PAs, NPs, DOs, MDs, the opportunity to participate in an 8-week MBSR course, actually with Zaida Vallejo and Anna Rosenbaum, who came for that initial program. And as part of that too, we also had 14 behavioral healthcare providers, some who were integrated into primary care and some in our outpatient psychiatry department, who all also began the process of MBSR, and most of them moved on to proceed to go into our group leader training program for mindfulness training for primary care, and then helped to co-lead the groups in primary care sites. So that was a real investment of support by the hospital system to really believe in the potential value that having mindfulness, having people be able to have this capacity to self-regulate and to manage what's going on in their mind could really help them then be able to manage their chronic illness and health. So that really was a big investment of time, and by the department, by the hospital. We also had support from the Gold Foundation as well as the Arthur Biden Davis Foundations with the System Transformation Grant to really help get this started. So
that's a lot of moving parts to
yeah,
offer this service to people that otherwise wouldn't have access to it.
I think that's right. I haven't shared this that openly, but I trust your listener base to hold this warmly. But another piece was I was transitioning actually back at the time from where I'd worked at Mass General Hospital, where I started doing research on mindfulness. I had been a chief resident in addictions here at Cambridge Health Alliance, and as this opportunity was presenting itself, there was also a real need for more opiate treatment back here after I finished my fellowship at Cambridge Health Alliance. And when I transitioned here, I actually was dealing with some chronic illness myself after having had a really severe pneumonia that damaged one of my lungs. I had kind of this chronic pneumonia that continued to worsen. And in that context, I actually had such a bad pneumonia that I collapsed and was hospitalized for the pneumonia and what turns out to be bronchiectasis, which is kind of damage to the lungs, similar to what people with cystic fibrosis have, but without the more global effects. And so in that context, I actually was off from work for 2 months. And it was during that time I was thinking a lot about the importance of self-management around chronic illness and the role that mindfulness had been playing just in helping me to cope for these years that I had been with this illness since the lung damage happened. and really thinking about how do we really apply all of the skills and wisdom that comes with mindfulness, not just to de-stressing, but to actually making health behavior change and and to really change our capacity to be able to manage chronic illness. Because at that time, I was under the impression that I had about 4 years to live based on what they told me. I should say this is now 7 years out from that time that I heard that. So I think that I really wanted to transition some of the work that I had been doing from the addictions field around self-regulation and behavior change, and really try to think about how to help apply this and what I was applying to chronic illness more generally. So kind of in that context of being home, I worked from home with some of the other faculty members and residents, and we put together these grants and the Senate proposal. And soon after I returned to work, it got funded. So things work in funny ways. As they say, sometimes when one door closes, others really open. And I think that the center has continued to grow since then. One of the things that we were really lucky to have early on in this group leader training is some amazing psychotherapists who had previously started the Victims of Violence program here at Cambridge Health Alliance, which has been a national leader in thinking about developing trauma-informed mental health care. And so with several of those experienced psychotherapists joining our team and going through the MTPC group, Mindfulness Training for Primary Care, MTPC group leader training, we really were able to develop a trauma-informed training from the outset with the idea that anybody who's coming to our program could have trauma and that it could come up in various different ways. And we needed to really think about how to adapt mindfulness and our system to be able to support all of us who may have some trauma that we bring to this program. So I think that's one other important piece that I feel really glad that we had that encouragement from the outset.
Yeah, I'm glad you bring that up, because we've talked about that on this podcast many times, that mindfulness is not a cure-all. It's not always the right time for everyone to take a program. It's why we have such extensive application processes. For example, prior to taking an MBSR program, you don't just sign up. It's an application to make sure that this is not going to be harmful to you and that you have the support you need that may be appropriate for you in your context. And we've had David Trelevan on to speak about trauma-sensitive mindfulness, and understand that a little better, because even in mindfulness circles, it can be difficult for teachers or those who have been practicing for a long time themselves who may not have trauma as part of their background, or they have, and mindfulness was a great way to help them really understand that it can also be re-traumatizing. Certain kinds of meditation can be unhelpful. So thank you so much for building that in to the programming.
Yeah, it's a key and important area. And part of what we did was look at MBSR, which I consider like first generation, and then look at all the second generation mindfulness-based interventions, or MBIs, that were adapted from it, like MBCT, mindfulness-based cognitive therapy, mindfulness-based relapse prevention, MBRP. You've got to love acronyms if you're in that. We also looked at mindfulness training for smokers, which I had worked on with Jeff Brewer on some studies. We looked at mindfulness-oriented recovery enhancement, which was conducted by Eric Garland for chronic opiate misuse. We also looked at mindful self-compassion, which was started by Kristen Neff and Chris Germer.
Chris Germer, yeah.
Who's one of our faculty members here, and I should say was my supervisor in my fourth year of psychiatry residency, and has been a wonderful mentor and teacher for me. So we really looked at how do we take the kind of core of MBSR, that is this idea that there's more right with us than there is wrong with us, and that it's not diagnosis specific. We all can access this, and it's not just about kind of solving one specific problem that we have. So how do we take that kind of ethos for a mixed group in primary care, and at the same time augment it from what we've learned over the last 20 years in all the science, all the clinical science around MBI development, and around some of the specific adaptations that have been done in MBCT, MBRP, MORE, MTS, and MSC, to be able to really take all that's working in the best programs that we've felt have been involved with helping people make behavior change and integrate that into a new 8-week program that can be referral-based, insurance reimbursable, trauma-informed, and that could really have an 8-week flow that's designed to help people not just reduce stress or reduce some kind of symptom or prevent some kind of relapse, but to actually help them initiate and maintain behavior change and in a broader context, help them to identify what it is they feel like they need to change and to be able to do that. And outside of any kind of specific context of values in a diverse safety net primary care environment with people coming from all different cultures, how can we help them to be able to identify what are their values that help them live well in their life, and to be able to use mindfulness related skills to be able to engage that. And so what we did was set up a randomized comparative effectiveness trial where we really didn't want to buy. What happens a lot in mindfulness trials is people get biased because they know it's a mindfulness trial. And so there's the mindfulness group and then there's the other group that people then feel kind of disappointed that they're in. And so what we tried to do was really only enroll people that wanted to be in a mindfulness program because we felt like that actually was realistic from a comparative effectiveness standpoint, and that the actual comparator, the kind of current standard that's going on right now really is an hour of mindfulness or some kind of intro to mindfulness, and then really just encouragement to get on digital resources, to use community programs, access community centers that are private pay generally in our area besides ours, and to read books that relate to mindfulness. And then we called people every 2 weeks as well and encouraged them to practice in both groups. So one group got 8 weeks of this mindfulness training for primary care program. That was eight weeks for 2-hour sessions with a day of silence. That's not a billable session, but it's something that our group leaders kind of co-lead all together for all the different groups that are going on in the region during that season, so that we can bring together community, in most cases from multiple primary care sites, together to create community. And we compared that again with this introduction and then referral to community resources with encouragement to practice. We did 2 different phases of the study. In the first phase of the study, we actually asked people to meet with their primary care provider and to review in collaborative decision-making way what their goal might be for living well, and to make sure that it's something that their healthcare provider thought would be helpful for their illness or their health maintenance. And then we looked to see 2 weeks later if they had in fact made that change or not, had they started that change. And so both groups were encouraged to do that. What we found actually in this first study was that people had more than 4 times the odds of catalyzing or initiating some kind of self-management behavior change if they had gone through the 8-week program compared to if they just had the low-dose comparator. We also found that the 8-week group was more effective at reducing anxiety, enhancing mindfulness, and enhancing self-compassion. This was a study of, I think, 344 patients were referred over the course of about 14 months, and we randomized, 81 people, 2-to-1. So we had twice as many people going into the mindfulness condition as the low-dose comparator. And then after 6 months, people that did complete the low-dose comparator condition were able to join the group after that with their insurance. And so it was insurance reimbursable. People did have a copay though. And that was, I think, one of the biggest surprises of our program, was that we really felt like, oh, we're going to do this with insurance, it'll be free. And, in our region, an MBSR course or a mindful self-compassion course might cost, $600 to $700 in private pay. And with some insurances, like with folks who had the Medicaid or Medicare products, they really did have it for free. But there actually was a very large percentage of people who were in the subsidized insurance, federally subsidized insurance, which in the Affordable Care Act, I guess it would be people that were just a little bit above the poverty level and therefore had substantial subsidization of their insurance. And for those folks, I actually found that I think our team found to our disappointment that it was in some ways they were able to participate, but they were hit with these copays that, still had them paying about $200 to $250 over the course of the 8 weeks, just because they get hit with a $30 copay every time they showed up. And so that was really, I think, one of our surprises in this. That being said, 50%, more than 50% of the people that participated in the program were on subsidized insurance or Medicaid or Medicare products, which really we felt like was a success to be able to demonstrate that was possible. And we had some workman's comp, and then we also had some private insurance as well. I think another important piece that we looked at in looking at whether or not we were successful with implementation was how diverse was the population. And what we had found, actually, as I just mentioned this, is that overall, from an income standpoint, 62% of the population that enrolled in the study were actually at annual incomes less than $40,000. So I think from a socioeconomic diversity standpoint, we met our goals. From a race standpoint, we have in our population in this region, it's about 2/3 white, about 66% white English speaking as a first language. And so we really wanted to get as close as we could to having a third of people either being non-white or speaking a language other than English as their primary language. And so what we found was we had about 22% non-white, and then we had 15% with English as a second language. So between the two, there's a little bit of overlap between those, but between the two of those, we think that we roughly had around somewhere between 30 and 40% that met that goal. And so that being said, I think we were still disappointed because a lot of those folks were the ones in that subsidized insurance that ended up getting hit with large copays that we felt disappointed about. Another thing that happened that we've noticed now over the 2 or 3 years was that, so one of the things that we did, as you said, to make sure things were safe and in the healthcare system and for billing purposes as well, in order to be in a group that's billed to insurance, you have to have had behavioral health evaluation. And so everyone starts in our system by getting referred by the primary care provider or their healthcare provider for an evaluation. If they're already in treatment for mental health care, then their mental health provider could vouch for them. But one of the things that we noticed is that when people of color were being referred to the healthcare system in general, either they were being overdiagnosed, so that anger, rage, or other types of behaviors are being perhaps interpreted as more severe mental illness, or people were less likely to seek out care until the mental illness is more severe and bring it to the attention of themselves or their community. And so there is some data suggesting that people don't seek mental health care as early on because of stigma and because of historical biases that have occurred in healthcare.
Well, I'm curious if you're really good reach for diversity in the population taking part in the study, if that presented some challenges with recruitment.
Well, so that was one of the things that I think was particularly hard for our recruitment coordinator at the time, because we had exclusion criteria around some of the more severe mental illness. So a lot more people of color ended up being excluded because of the exclusion criteria, because there was higher severity of mental illness that was coming in on the diagnoses prior to,
with potential bias from that diagnosis rather than.
Is it bias or is there selection bias? We really weren't sure, but that was something that I think I'd say, that kind of hurt us in our hearts to be witnessing as people were really seeking mindfulness, and we built a system to be able to support them. And we did see a lot of people that were able to take advantage of it, but it's still, anytime you have to deny anybody who is really seeking mindfulness, and it feels like it could help them in some way, maybe not this program, but some way, it's hard to not have that accessible to them. One of the things that actually caused us to do as a center was to work with the hospital system to develop our mindful mental health service. And so we now have a clinical service in our outpatient psychiatry department that kind of runs parallel to our standard mental health care treatment, where we actually can have people that are seeking mindfulness with almost any level of psychiatric comorbidity or symptoms could still be able to find a mindfulness group that would be fit to them. So we have intro groups for people with anxiety and depression, but then also intro to mindfulness groups for people with addiction, for substance use, active substance use, people who are coming in with severe mental illness like psychosis or bipolar disorder, as well as a group for people with severe trauma that was too intense to be able to come into this group, into the primary care groups. And then what we do is, as people develop in the intergroup, 2 or 3 times a year, we'll make a mindfulness-based cognitive therapy group accessible for people, for those that are ready, and their group leaders will know if they're ready for that or not. And so it gives us a little more of a weekly way to assess and support people and to know if they're really ready to go into that kind of group. And then after that, we have alumni groups for ongoing practice and community support. So we actually have recently started a advanced fellowship in mindfulness and psychotherapy, with this focus on learning how to run groups in the healthcare system, both MBCT and mindfulness training for primary care, and to help doing this kind of evaluation and management for folks that really want a mindfulness-based approach to their mental health treatment. And we also have one group that's starting that's in Spanish in the mental health service as a way of helping to fulfill community needs. I guess the last thing I'd say is that when we started to see this, we have a large Brazilian and Portuguese population here in Massachusetts. It's about 14%, and we have about 12% Latino or Hispanic, Spanish-speaking population as well. So we actually been collaborating with multiple partners throughout the Brazilian community and Portuguese-speaking community in the region. And so we had our Mindfulness Training for Primary Care program translated into Portuguese and adapted for Brazilian culture through collaboration with Mente Aberta in Sao Paulo, Brazil, and pilot tested actually in the Brazilian consulate and some other places for cultural adaptability, acceptability. And we've been running those groups in primary care as a pilot for the last year. We actually just found out that this was funded with some additional funding to support that in this ongoing year. I have a fellow come from Brazil to continue this work with us. So that's been one of our focuses. We also have been translating our mindfulness training for primary care into Spanish through collaboration with the University of Zaragoza in Spain. And we're getting ready this fall to start our Spanish mindfulness training for primary care group. So just to give you a sense of our commitment to trying to make this accessible. The last thing to say about this initial pilot study was that what we found was that 49 out of 50 people had a good idea of what their health behavior change was that they needed to do for themselves, or their chronic illness self-management change was, without talking to their primary care provider. And only one person actually changed after talking to their primary care provider. And what we found was that the levels overall, people initiating health behavior change were low. And we thought that the requirement to meet with your primary care provider to make a health behavior change was likely a barrier. And so when we designed the second phase of the study, we actually removed that and instead gave everyone in both arms a 3-minute animated explainer video about how to set a SMART goal, a SMART action plan goal, specific, measurable, attainable, realistic, or reasonable, and time-bound or timely. So everyone got that, and then everyone set a goal online that then we could follow up with 2 weeks later to see whether or not they made that change.
How did that go? Did that work a little bit better than the first?
Yeah. So I can tell you about that study. This study's actually been published in the Journal of General Internal Medicine. What we found was that somewhere between 2.2 to 2.9 increased odds of having a health behavior change initiated within 2 weeks in the mindfulness training for primary care group compared to the control group. So we found a similar increase in this group as well. And I should say this second study was actually done with monitoring through the National Center for Complementary and Integrative Health, NCCIH, and we had funding through the NIH Science and Behavior Change Initiative. And so partly what happened was because of our interesting and compelling findings in the initial trial, really working together with our Mindfulness Research Collaborative, which was an organization that I helped start with several other folks about 10 years ago now, with people at Mass General Hospital, at Brown, at UMass Center for Mindfulness, Vanderbilt now, and Georgetown. We've been working together to try to understand the mechanisms of mindfulness, neurobiologic mechanisms of mindfulness meditation. And we got interested and we applied to use this study and another study at Brown, which both were studying primary care chronic disease populations to see if we could figure out really what are the mechanisms through which mindfulness impacts self-regulation and what are some neurobiological assays or tests that we can do to be able to see if we can test that, and then look at how does that change in self-regulation capacity impact people's capacity to make health behavior change. So we were funded under that study to replicate the trial and to begin to do functional MRI neuroimaging, as well as other types of testing to really get at and understand some of these mechanisms involved in self-regulation. So the second study was with 136 people. It's a similar design, except for that change that I mentioned of removing the PCP requirement. And we actually found that by removing the PCP, 20% of people in both groups were more likely to initiate a health behavior change by allowing them to do it on their own without having to have to talk about it with someone. I think most people do have a sense of what might be needed for them. And one of the things that we really wanted to see in the second study was whether or not interoceptive awareness, and which is your capacity to really pay attention to body sensations and internal body sensations, and emotion regulation would be impacted by our mindfulness training for primary care program in a way that was greater than what we saw in our low-dose comparators. And in that study, we did find substantially and significant increases in both the difficulty in motion regulation scale as well as the MAIA multidimensional assessment of interoceptive awareness. So that actually has now led us on to the third stage of this study with 114 people, which is also including activity monitoring and other types of behavioral monitoring, daily monitoring, as well as multiple neuroimaging tasks looking at the way that the brain functions during self-criticism and how self-compassion training and mindfulness training may impact the brain's networks involved in self-criticism. We're looking at the way people regulate pain and as well as the way people regulate their interoceptive attention. Those are some of the things that we're doing, as well as looking at inhibitory control and sustained attention. And there's more. Your audience can ask me more details.
Well, one of the things that strikes me about what you're saying, Zev, is that what's coming clear in your care about these programs, about the people involved with them, that while there are certainly numbers which are indicating efficacy, that this is not dry, that efficacy is about people, is about the suffering that they're going through, chronic illnesses, severe illnesses like your own and others that we know who've been helped with a mindfulness practice that may not be curing the physical malady, and that it's not supposed to. It's about something else. And it's meeting people who otherwise would not be able to get to because it's inaccessible for various speed bumps that for many might be speed bumps, but for others, particularly those who may be disenfranchised in some way or have a difficulty like a chronic illness. And that example of just a visit with a primary care, that can be a huge problem to overcome. What I hear throughout what you're saying is the care for people who are hurting. And this is one of the things that why I am so grateful to be involved in the work of mindfulness in the world is that I've yet to see it for anything else. And I'm wondering if you're able to share if there are any stories from just the experience in these three phases, knowing that you're gone through 1 and 2 and are working on the third phase now. If some of that, the less clinical side, the less numerical side of stories, if there's anything that stands out for you that touched you personally that you're able to share.
I think some of the things that have stood out to me, one patient actually wrote this beautiful letter to our CEO, thanking him for the kind of integrated care that he had. He had chronic pain and depression for years. And it was just, he clarified it so well, that he felt so cared for by having this entire team, his primary care provider, his psychiatrist, his psychotherapist, and his mindfulness team, all working together to help support him. And in that context, feeling like this time that he spent taking care of himself was definitely the most time well spent, because he learned how to take care of himself and really had reductions in his pain and depression. I think maybe one of the most prominent stories I can think about from our time was one of our patients who actually was referred. She had a trauma therapist she was working with, and the trauma therapist who, understood what we were doing felt like she should and could benefit from this work to work with her dissociative symptoms that she was having, which she would kind of go into autopilot whenever she was stressed or there's something to avoid. And part of the MTBC groups is that we often have 1 or 2 people that, maybe have a few more needs than everybody else. And we try not to have more than 1 or 2 people that really have more than those needs. Generally, our groups range from 8 to 12 people. So that's important to say. It's different than MBSR, which has much larger groups. And that's for actually billing reasons that we have to do that for CMS, Center for Medicare and Medicaid, limits on group psychotherapy billing. Just the way that our group leaders worked with her, that she was able to identify that she would have these dissociative episodes, and how she continued to have them, which actually was more scary for us as clinicians than it was for her, because she was so used to them in a certain way. But her husband would actually come and sit outside of the group for the 2 hours, and we worked it out that she could go and leave at any time, that she needed to go out there and sit with him, and they could come back. And for our group leaders to be able to work as a team, talking about that, communicating with a therapist, that by the end, this patient, who I think many people would say would never be able to have been in a mindfulness group, was able to substantially benefit and really felt like she had greater sense of control over the ways that disassociation was impacting her life. And this was actually, one of the giant surprises for me in this second study that we did, where we actually did have more people who had PTSD like this in the study, that in fact 11 out of 12 people who were in the mindfulness training group actually initiated a change. So some of the people that did the best in our program were the ones with the most trauma symptoms. Mm-hmm. And that really spoke to what we were doing. We have 28 qualitative interviews that we've done, and we've been working on synthesizing these data. But one of the things that we found is that in the end, whatever the action plan people decided on for those 2 weeks, what we found is that has not been the most important thing to them long term when we talked to them at 6 months. But that for many of them, this helped them to learn how to make changes in their life, or how, maybe even better say, how to allow changes to happen towards living well. And that they were able to do that more and more with other things, and with deeper and bigger changes that they felt like they needed in their life. And so for me, that's one of the things that I stood out from my discussions with those that have been doing that. I can't say much more about it because we're still working to publish that.
That's all right. Thank you for sharing that. I appreciate it.
Just we actually had somebody in one of these groups who had opiate use disorder and was tapering off of her buprenorphine medication. She had really huge impact from this group. And I guess it makes me realize, even before I go into that, I should talk a little about what the curriculum is, so people can get a sense of how what it is and how it differs and how it's similar. So it is an 8-week program. And the first 4 weeks are very similar to MBSR and MBCT as far as the development and cultivation of mindfulness. But one of the things that's different is that we have 3 different threads that are woven throughout each session to help support what we believe are key ingredients that are required to be able to successfully initiate and maintain behavior change. So the first was to actually have some awareness around behavior. So we actually start in session 1 with, I like to think of it as a scavenger hunt, a group scavenger hunt, but really looking and noticing autopilot in 10 different ways and all the different ways that we might have autopilot. So instead of just focusing on one routine activity in daily life, we really get people going just to find all the different ways that they go into autopilot. And then we have everyone come back and mark on the board at the beginning of session 2 all the different ways that they might have experienced autopilot. And what we find by the end is that literally every category is checked off, generally with more than one. And it's kind of this feeling that we kind of came together to really start to pay attention to autopilot in our daily life. So in each session, the session themes are kind of brought towards this question of behavior change and also what is living well for you in your life? What would it mean to live well with chronic illness, with anxiety, depression, stress? Mm-hmm. So another thread that's kind of going through each session is the role that compassion, kindness, warmth, and common humanity really plays in. This is really coming out of our understanding of the mindful self-compassion curriculum that we've been running here for multiple years, and through some of Chris Germer's wisdom, really the key role, and not just having it be the hidden curriculum, but really finding ways to help it be explicit and help people understand what they're doing and to develop that. And then the third thing is that interpersonal mindfulness is incredibly important. And many MBIs do have some dyadic work at different times, or triadic work, but we really explicitly ensure that each session has some interpersonal mindfulness, and people layer their capacity for this interpersonal work in each session, developing greater and greater capacities to be able to do that, with the idea that we don't make change alone. Change doesn't happen alone. In fact, it involves our community and stakeholders, and we need to learn how to be able to bring mindfulness into the communication with others, and to see others fully in their presence, to learn how to do that. So those are 3 threads. So then in session 5, we introduce kindness and coping. We do it actually a little bit earlier than it happens in MBSR, partly because you really can't make change and maintain it in any way without this capacity for kindness, because otherwise it ends up being too forced. And then when you slip or you fail, even just briefly, you have these global attributions and self-criticism that derails things. So we really try to bring that in a little bit earlier. And the second thing is that we found that because we have the trauma-informed program, we wanted to bring in the self-compassion as early as possible in various ways in order to allow people to figure out how to be kind to themselves and to give themselves what they need. And it's really a way of making a safer program. And I think that we've done that. In session 6, we have adapted actually from Bill Miller, who was the developer of motivational interviewing, developed a values card sort process about 15 years ago that I'd been using clinically in my addictions work. And we adapted some of the values, but kept like the underlying process for helping to clarify one's values, and really added a kind of a mindfulness frame to it. So it's not about what values we think we should have. It's about becoming mindful about what values we actually have in our lives right now, which can sometimes be a reckoning for people. And it's often a very emotional session. But also be kind to ourselves about that, bringing that self-compassion and kindness in with ourselves about where we are. So we have to see where we are before anything can be able to change. And then really thinking of the values we have, which ones are helping us live well in our lives? Which ones will lead us to feel like we've lived life the way we'd like to, in a way that's grounding and healing for us? But not picking values that we don't have that we think we should have, because you can't start making change and bringing in values we don't have. You can start to cultivate values, and if you notice there's a value you don't have, well, you can start to set an intention to cultivate it, and maybe it'll start to emerge, and then you can really bring it in as a core value later on as things change. Then in session 7, we talk about wise action and how to be skillful or unskillful in making change and setting intentions and aspirations for change, how to hold a desire for change and just right, like as if you were to get an egg in your hand, not so tight that you crack it and not so loose that it falls out of your hand. And how to really allow change to emerge in a non-attached way, but continue to have skillful effort towards helping that change emerge. And the role of planting seeds, that we can't necessarily make ourselves think something right now. We can't even make ourselves do something right now. But if we keep setting intentions to do it, if we keep planting seeds towards it, and keep avoiding planting the seeds that are taking us in the other direction, then ultimately that change will start to emerge. And then finally in session 8, we really move into thinking about communication, connection, and community. And we actually have an adapted, similar to the Aikido and MBSR, but we call it the box of help. And we have people give each other a box with all sorts of recommendations for medical changes they should make or health changes they should make. And we go through all the different styles of the way people relate to receiving support and help around their health behavior change, with the idea that people really need to identify who their stakeholders are in their change, both to help them change and to help them understand where they can go for advice for health-related change. And so that's kind of the flow of the program. And I guess just to get back to this patient I was speaking of previously,
Yeah.
And I've had this experience now doing this values exercise in multiple groups, that sometimes people, it's a very moving part of the experience, an intensification of the experience of bringing mindfulness really to being aware of our behavior and the seeds that end up motivating our behaviors in a deep way. In this case, she actually was so moved by the values exercise that after she actually tapered off of buprenorphine successfully, which is very rare, by the way, and I don't generally recommend it, but she was using mindfulness skills for several years and was able to do that. Actually, on her wedding day, she told me that in the hour before she went out to get married, she actually decided to spend the last half an hour doing that mindful card sort as a practice, because she'd been doing it regularly as a way to help orient herself to what it meant to live well. And that for me was just so touching, that these practices and the ways that people are integrated into their lives are just beyond, what I ever imagined the impacts it could have. I think that is the power of mindfulness, is that we think that it's just paying attention, and before we know it, there's a lot of transformation that starts to happen.
Yeah, and that accessibility that is so important in the work you're doing is honoring and understanding that everyone who engages in these programs has an entire lifetime of unique experiences to them, and it's going to manifest and take root in different and unique ways with each of them.
And I don't know what values you need to help you to live well. I worked with another young man who I did this mindfulness exercise with, and he identified that one of his top 3s was machismo. And that was not necessarily, I just say, one that I had thought about putting onto the cards, but he wrote it himself, and he really very much felt like it was important to him. And I would say that I'm not sure that it's aligned with a lot of what people think about as kind of a mindfulness related value. But I'll tell you, the way that machismo and mindfulness interacted for him actually really led him to make substantial changes in the ways that he was using substances and made a change. But it was what he needed, and it was what he felt would help him, and that was what was important. And so, I think that's one of the unique things about this program is really helping people identify how they think they'll live well. I guess one last thing I wanted to say, and then I think I will have shared most of the key aspects of this curriculum, is that we actually also have a informal mindfulness practice that builds on itself and changes as it goes through the 8-week program. So we call it Stop, Ache, and Go. And it's really built on this premise that so much of autopilot behaviors are about experiential avoidance. It's about, avoiding some feeling, some body sensation, some thought, some urge or emotion by moving into an autopilot habitual reaction. And so really what we need to do is stop. We need to feel that ache before we go again. And so we actually break that down and build and bring in some of the best informal practices from other programs into this. And I'll just go through it if you think we have time for a few minutes to say what Stop, Make, and Go stands for. So STOP is, stopping when you notice you're caught up in something, when you notice that you're stressed or you are caught up in an autopilot, or if you can't even stop, just trying to slow it down a little bit, slowing down the autopilot. That's the first step for week 1. In week 2, we introduce starting to stop, slow down, and then turn towards your experience. And if you can't even turn towards experience, then just taking notice of breathing for a few breaths. So those are the T's. And we really see that with any informal practice, there have to be at least 2 different pathways. There needs to be choice, in what people feel like is right for them, and kind of developing one's own skillful or wise navigation with mindfulness. Those of us that are more experienced practitioners know that we've had to learn to trust ourselves to navigate what we need at any given moment. And so our informal practice has that built in. There's these kind of constant off-ramps from experientially being with, but in a way that allows you to be able to come or stay with it in some way, not just avoid. So turning towards experience or taking notice of breathing. Then the third really is observing your present moment experience and with openness, and doing that in a way that we call our diamond of experience. So if in that diamond, every moment of experience seems to have some kind of thought, content, some emotion, some body sensation, and then at the other side of the diamond, some kind of urge to do something or behavior. And then in the middle of that is feeling tone, or this pleasant, unpleasant, or neutral valence of the experience. And we're usually reacting to some aspect of the diamond of our present experience. And so the P is really then noticing, observing what's there, what's my mind aware of now, and then noticing the pleasantness, unpleasantness, or neutrality of the experience. And then from there, we're ready to really allow the ache to be there. So the A is allowing or accepting that the ache is here, noticing that there's suffering here, and trying to allow it to be there. And for some people, that's too hard. And so they can anchor in their breathing, they can anchor in sounds, they can anchor in the sensations on their feet. And again, this is another kind of trauma-informed pathway to be able to allow people to have a way to navigate this, and then come back again to trying to allow it to be there. And we suggest people allow it just to be there for a few seconds, whatever it is that's really there in the mind, without pushing it away, without that reactivity of pushing it away. But sometimes that's hard. And so there's ways that we can hold what's there. One way that we hold what's there is through curiosity, especially around things that are very pleasant. It's important to kind of stay curious about them and not caught up in them. Another way really is to bring compassion and kindness to our experience, especially when there's very unpleasant and there's a lot of suffering there. It's hard to hold. Bring some compassion to our experience. It's helping. That's the C in the ache. And then H is really holding ourselves, either holding our heart, maybe holding ourselves at our elbows. It could even be some soothing touch, just to help us to be able to be with this experience for a moment longer before, without kind of moving into some action or autopilot to avoid. And then once that's happened, then the E is to start to expand out, to the breath, and then to bringing awareness out through the extremities, and then out to everywhere around you. And then you're ready to go. But before we go, usually we take a moment just to feel what it feels like in the body, to feel a little gratitude that you have this practice, that you are as healthy as you are, that you're able to practice, and to connect with some of, at least one of the grounding values that you were able to identify, really as what I call a foothold to help you to move forward in the direction a different direction than you were going in previously. You really need a grounding value. Grounding values really can help to be able to get a good foothold when you feel like you've been slipping. And then from there, we open to life's beauties and life's challenges, and try to orient ourselves to each moment with kindness, and carry that as we go forward. And so really what we're doing is we come into each autopilot moment, and each moment with whatever behavior or stress, really in this avoidance mode. And if we can just turn a little bit and stop to feel the ache with using all the mindfulness related skills and ways of being that we've discovered, then we're really able to go forward in a new direction. So that's the practice that we teach and build on and layer with each session, and that people bring with them as they leave as the practice. And it kind of has elements of at times as elements of a 3-minute breathing space, at times as elements of a MSC self-compassion break, and kind of integrates, I think, the core qualities into one fully integrated and comprehensive practice, which I'll just say I kind of came to through my own experience of my chronic illness. And for me, one of the biggest things was that I ended up having a lot of shame around having to take medication every day for my health. And I would go off my asthma or lungs would kind of stabilize for a few weeks, and then I would immediately start to think, I can cut back on my asthma medication or whatever I could do. And before I know it, I'd be right back there again. And when I really stopped, observed what was there, I had thoughts that I was broken. I had these like deep, sad emotions and shame emotions that I actually, like, previously, just despite all my mindfulness practice, I wasn't seeing. Because they weren't at the moments when I was sitting to do mindfulness practice, and because they were so deep, and because there was so much affect, so much feeling actually there that I was subtly, avoiding them. And as I brought this practice to that, really just being with it, there was just, a lot of release around that, and being able to learn how to really be kind to myself and give myself what I needed, and have some compassion that, what I was going through was not that different than what so many other people go through, but it's always harder when we feel like it's about us. And so this practice really helped me to move out of that, what felt like constant chronic illness state. And I've lived more than the 4 years and plan to keep on going.
Great. And glad you are. And is there anything else you want to share with the listeners before I let you go?
Well, we had our first mindfulness training for primary care group leader. I should say our second mindfulness training for primary care group leader training since our initial one, here at our new Center for Mindfulness and Compassion. And it was really, really wonderful experience seeing other people from other sites who are coming to learn and bring this to other healthcare systems. And I think we're excited to think about how our experience can potentially help others that want to bring mindfulness training into their healthcare system and into primary care or other aspects of the healthcare system. It's been really an amazing experience learning how to work with organizational change and the vast array of stakeholders and specifics of integrating mindfulness into healthcare. Our website, it can be found online.
Yep. And for those listening, I'll be putting a link to that website on the episode page for this episode. Our guest today is Zev Schuman-Olivier. Thank you so much for being here. Really appreciate the conversation today.
Well, thank you for inviting me. It was a pleasure.
Thanks for listening. If you'd like to learn more about something you've heard in today's podcast, please come visit the website at presentmomentmindfulness.com. You'll find an entire webpage devoted to this and every episode. You can comment on the episode page and find show notes and other helpful resources for your mindfulness practice. The shakuhachi music heard on Present Moment is used by permission and through the generosity of musician Rodrigo Rodriguez. His website is linked on the Present Moment website on the About Podcast Music page. Sound editing, mixing, and mastering provided by the generosity of Anthony Dominello of StructureFromSound.com. Until next time, remember, every moment you have a choice. Make it the best you can. See you next time on Present Moment.